adaptive pressure control ventilation has been marketed as a hybrid mode of ventilation, one that provides the best of both worlds. I can target a tidal volume similar to volume control ventilation. However, the machine uses pressure control to meet these targets. And since it is a pressure control mode, if the patient's inspiratory flow demand increases, then the variable flow rate will meet these patients' inspiratory demands. Hi, I'm Scott Ritchie, and today I'll be discussing why adaptive pressure control is not ideal for certain patients. This image displays flow mismatch, which is a common ventilator asynchrony in volume control ventilation. This happens when a patient's inspiratory demand is high, usually a result of greater minute ventilation needs, often seen with patients with severe sepsis, or in burn patients also. So as you notice, we're going to look at the image, and my cursor you can see on the right hand side of the screen. We're in CMV. This is just volume control continuous mandatory ventilation, and I have a set tidal volume of 500 here. With this tidal volume of 500 and the flow rate and the I time setting, you notice I have a very slow flow rate of less than 25 liters per minute. So we're going to look at this purple waveform here. This is going to stay pretty much constant since we are in volume control ventilation. And when we are in volume control ventilation, to diagnose asynchrony, my pressure waveform is going to be actually the most diagnostic. So we're going to look at this yellow pressure waveform here on top. And here are my measured values to the left-hand portion of the screen. You notice my measured tidal volume is approximately 500 cc's, and my measured peak pressure is 27 centimeters of water based on this patient's lung mechanics. You notice the resistance is a little high here, and the compliance is pretty low. So this patient, this screenshot is frozen, and as you notice by the snowflake here, and I scrolled over to measure some things. So as you notice, these breaths are machine breaths, and the patient starts to spontaneously breathe, and they're spontaneously breathing here, and they're sucking back so much that it's creating this big divot here in my pressure waveform, as you notice. So my flow is constant, I'm not getting enough flow, and that's why the breath looks like this. As you notice, my peak pressure has been constant around 27. However, when we look at the pressure here, my pressure dropped to 2.6. So the patient was sucking back pretty much. So that was, patient was sucking back, if we look at a 27, and then we think about approximately 3, they were sucking back about 14 centimeters of water. And depending on your trigger, they could have triggered additional breath and created double triggering if they would have sucked back deep enough. So this is an example of what happens during a vigorous inspiratory effort or a change in minute ventilation demand in volume control ventilation. It usually results in flow mismatch, which is a flow asynchrony. And what the practitioner has to do is, to meet this demand, they're either going to have to increase the tidal volume or increase the inspiratory flow. So most likely they're going to increase the inspiratory flow. We have a lot to play with here. So I have a flow rate of under 25. I can turn this flow rate up by directly turning on my flow if you have a flow setting, or decreasing my inspiratory time. However, we're going to get higher peak airway pressures with that. Now, what happens if you're using pressure control ventilation and the patient has a high vigorous inspiratory demand, their minute ventilations change? Well, in this picture, this is an example. This is a screenshot taken from a patient in septic shock. Now, this is pressure control ventilation. As you notice, the top portion of the screen is my pressure waveform. I have a nice square waveform here. Since we are using pressure control now, my most diagnostic waveform is going to be my flow waveform, and that's the second or the bottom waveform here. And we want to look at this waveform. for diagnostic purposes. Now, in previous videos, I mentioned that if you're using pressure control ventilation, the patient should be able to get all the flow they want. And flow is kind of independent of the pressure control setting. However, that is all dependent on what pressure control level you're targeting. So there's a misbelief that you cannot have flow asynchronies when using pressure control ventilation. However, you can have flow asynchronies during pressure control ventilation. And now I'm going to show you an example of this. So here's pressure control ventilation, as I stated before. And what's happening is this patient's in septic shock. They have metabolic acidosis and their inspiratory demand is very high. And what you're seeing here is this flow scooping. So during my flow should always, in pressure control ventilation, my flow should always decelerate towards a baseline. And as you notice, my flow is starting to decelerate. However, the patient's still sucking back and flow is rising again. So this is termed camelbacking. So if you see this camelbacking, this is a flow asynchrony. Now I can't turn up my flow or anything in pressure control. The only thing I can do is increase my driving pressure or my peak inspiratory pressure setting. As you notice, we're currently at a pressure control of approximately 25. We could possibly turn it up to 30 centimeters of water and see if this relieves this flow asynchrony. So this example, using pressure control ventilation with a patient with a huge inspiratory demand, that you still may have flow asynchronies. And what else you might see is high tidal volumes. So that's the bad thing about pressure control. Patients sucking in so much, you're going to have a lot higher tidal volumes too until they wear out. So let's take this to the ventilator simulator and show what happens when I'm using the ventilator simulator. Okay, here is my ventilator simulator of pressure control, and we're going to demonstrate what happens when the patient's inspiratory drive increases or there's a change in metabolic demand. You most likely will see these in patients that have ARDS, and the ARDS is secondary to a sepsis, which creates usually a metabolic acidosis, and they have a higher minute ventilation demand. So as you notice, I'm in pressure control ventilation. I'm currently in a pressure control of 18 and a high PEEP. I do have this set up. If we look onto the left-hand portion of the screen, I have it set up for an ARDS patient. So pretty normal resistance. My compliance dramatically decreased at 25. And currently, my patient has no spontaneous breaths. So I'm going to change that. I'm going to change the patient effort. I'm going to make them very vigorous. And as you notice, let's look at some measured values here. So here's my peak pressure, and our measured tidal volume right now is approximately 450. So we're doing lung protective strategies here. And we're going to look at my flow waveform, and we're going to look at my pressure waveform also. And I'm going to change the inspiratory drive to make the patient very vigorous. And I'm going to turn this up to, let's just go ahead and turn it up to 30. Get right to the point. So my patient effort is very high now. I'm going to change the rate. I'm going to add the 10. Patient spontaneous rate of 10. And let's take a look at some of my measured values and everything else. So this simulator might have some lag and it might take a while. As you notice, my tidal volume is the same. But it shouldn't be the same. That's why I'm surprised. Patient now has a very vigorous drive, and I should have a lot higher flow demand. Interesting. Let's see what my trigger set at. There we go. So there is some lag with the simulator. There we go. That's what I wanted to show. So we have a huge, and the patient is going to have a higher minute ventilation demand. And I'm going to just silence that alarm real quick. And I'm going to just change my alarm thresholds here. Expiratory minute ventilation. Let's just increase all this up. There. We'll auto set it. So as you notice, I have the same pressure control set of an 18. It gives me the same peak inspiratory pressure. However, my tidal volume went up. It doubled. It went up to a liter. So they have a huge flow demand, flow increase. So that's the benefit of pressure control. The patient get all the flow they want. However, it's going to give them these much higher tidal volumes. So what one would usually do is, well, they'll decrease the pressure control, but they'll end up with flow asynchronies here also. So this is why volume control ventilation is used a lot in ARDS, because I could set a tidal volume and that would be my threshold. So I have these huge tidal volume variance right here. Okay, here's a screenshot of adaptive pressure control ventilation. And we're looking at the last videos of pressure control, and someone might say, well, let's try to, instead of having these high tidal volumes, and we want to give the advantages of unlimited flow to the patient, why don't we just put it on adaptive pressure control? Then I can target a tidal volume and have less tidal volume variance, and then the patient can get all the flow they want. So this might seem like a good idea, however, it's actually a very bad idea. You can use adaptive pressure control on a variety of patients, but I highly recommend that you do not use adaptive pressure control for patients that in septic shock, have high minute ventilation demands, burn patients. This can actually create more worker breathing. Additionally, patients that are on high levels of PEEP. So if their PEEP is set, ARDS patient whose PEEPs are set above 12 and they have problems with oxygenation, you're going to have issues with adaptive pressure control also if the patient also has a metabolic component going on. What we're going to look at is we're going to look at my pressure waveform and we're going to look at my flow waveform here. So we're going to see a couple things. This patient has a high inspiratory drive. What the ventilator always wants to do is it wants to target that tidal volume you have set. So if the patient has a vigorous inspiratory drive, it's going to measure the tidal volume, and then it's going to always look at my expiratory tidal volume. So as you can see this happening here, the ventilator is kind of thinking, and every breath it's decreasing my pressure. So here's my pressure setting. And say you're targeting a tidal volume of 500, the patient's sucking back so much they're getting good tidal volume around 700, it's going to start titrating my pressure down. It's saying, hey, I want to target that 500, let's decrease the pressure. So you see the stair stepping here. And as you can see, the pressure gets lower and lower until it's meeting that target tidal volume, and we have this low pressure. So that's good, we have a consistent tidal volume. However, this increases the workload of the patient. Here's some things here we can look at. We started out at pressure 20, and it decreased to a peak inspiratory pressure around 8 centimeters of water. We're using very little PEEP, approximately 3, in this patient here. So as you notice, it's only about a 5 centimeter water difference. The patient basically put themselves on a spontaneous breathing trial. This would be an example of, a pressure. We use commonly pressure supports of 5 centimeters of water, 10 centimeters of water for spontaneous breathing trials. So this can really wear the patient out. So what you'll usually see happen is you'll see the stair-step pattern, and then they'll wear out, and then it'll go the reverse way. So this going up and down creates a lot of worker breathing and really fatigues the patient. Another thing, oxygenation-wise, is say you were at a higher pressure, this creates a higher mean airway pressure also. So these decreases in peak inspiratory pressure are also going to decrease my mean airway pressures. So I'll run into issues with oxygenation also. So that's why I highly recommend not to use adaptive pressure control mode in a patient with a vigorous drive that has their metabolic demand has increased significantly, or that's in high amounts of PEEP due to oxygenation problems. All right, this is my ventilator simulator, and I have it set up for that patient that's in ARDS. And as you notice on the left-hand side of the screen, I have it set for an ARDS patient. And I'm going to show what happens if we would say, okay, we want to target a tidal volume. In volume control, we're going to have flow asynchronies, we're going to have flow mismatch. In pressure control, they're going to get all the flow they want. However, their tidal volumes go up dramatically. So, well, let's just use adaptive pressure control. So I'm using this example. This is adaptive pressure control, even though it says CMV+. That's this ventilator's basically brand name for adaptive pressure control. And we're going to go into the controls to look at the settings. You notice I have a target tidal volume of 450, PEEP of 12, and a respiratory rate of 15. And here are my measured values. To maintain that tidal volume of 450, it takes a peak pressure of 28. And if we take the 12 out, that just shows that we have a pressure control of approximately 16 centimeters of water to get this tidal volume. I'm going to change the patient's minute ventilation demand. I'm going to make their inspiratory drive significantly more. And let's just see what happens during adaptive pressure control ventilation. So I'm going to change the patient's effort. I'm going to make it very dramatic, like if the patient has sepsis, or if they're a burn patient. And let's see what happens. So I'm just going to close this out. And we're going to look at my measured values. My minute ventilation demand is going to go up significantly. And the patient's going to be sucking back so much, my measured tidal volume is going to be more. They're going to get a larger volume for amount of pressure. So this created a high minute ventilation of higher tidal volumes. I'm just going to reset my alarm so it's not alarming all the time. And this is the lag I was talking about in other videos. It takes some time for the peak pressure to start titrating down. So I can still have these large tidal volumes, double of what I'm set, even in adaptive pressure control mode. So I'll have that until my ventilator catches up, because it's only doing it about 2 centimeters of water, 2 to 3 between breaths every breath. So as you notice, I still have a high tidal volume of 800. The patient's still generating these large tidal volumes. So what the ventilator is going to do is, to get this target of 450, it's going to start decreasing this peak inspiratory pressure. So we've already gone down on our peak inspiratory pressure significantly. We're starting at 28, so we probably went down 10 centimeters of water pressure already. So patient's still generating these high tidal volumes. And my peak pressure, with this ventilator, my peak pressure titrates down is limited. It's based on my PEEP setting here. So it's only going to drop my peak inspiratory pressure to 5 above my PEEP. So if my PEEP is set at 12, it's going to limit that to how low it goes. So 5 on top of 12 is 17. That's why it's not decreasing anymore. So to give you an example, I'm going to drop the PEEP to 10. Now I'll make it real dramatic. I'm going to drop it to 5 and I'll show you what it does. The ventilator will still decrease this peak inspiratory pressure to get this target tidal volume of 450. And come to think about it, we're only 5 centimeters of water above my set PEEP. So that is basically a spontaneously breathing trial. And this is severely going to have implications for the patient. It's going to wear them out, and it's also going to decrease my oxygenation status. It's going to decrease my mean airway pressure, so we're going to have oxygenation problems. And it's going to not offload the work of breathing. So my patient's going to wear out severely with adaptive pressure control in this situation.